webinar session organized by UDUAL and Universities Caribbean. We are very happy to have you today, and sorry for a slight delay in the start. So welcome to this webinar on public health and medical cooperation in the time of pandemic. I am very pleased to greet my colleague, Dr. Roberto Escalante from UDUAL, Secretary General of UDUAL. I am also extremely pleased to say that this session will be moderated by Dr. Javier Santa Cruz Varela. I will introduce him in a minute. And I just want to say thank you also to our three speakers who have accepted to talk today on this topic, and they come from across the Americas. So Dr. Jabor Azir from Martinique, Dr. Kalen Radix, who is based in the OECS in St. Lucia, and Dr. Orlando Harris, who is at the moment in California. So you will know more about our speakers who will be introduced just before their talk. So without any further delay, let me introduce our moderator for this webinar today. Dr. Javier Santa Cruz Varela has graduated as a medical doctor from the Faculty of Medicine at the National Autonomous University of Mexico, la UNAM. He has a master in public health from the National Institute of Public Health. He's a doctor in senior management from the Center for Postgraduate Studies. He has been the director for 20 years in the Ministry of Health of Mexico and the Mexican Institute of Social Security, and international officer for 13 years for the Pan American Health Organization. At the moment, he directs the subdivision of postgraduate studies in family medicine at the Faculty of Medicine at UNAM. He has various publications, and the most recent being training of general practitioners in Latin America and training of human resources for universal health in 2020, both in the Pan American Health Journal, edited by the Pan American Health Organization. So it is really my honor and pleasure to invite Dr. Javier Santa Cruz to moderate this panel, and to thank him on behalf of our two organizations, Universities Caribbean and UDUAL. Dr. Javier, the floor is yours.
Gracias. Thank you, Miriam. Muchas gracias. Me da mucho gusto. Gracias por la invitación. Me da mucho gusto estar en esta sesión con ustedes. He preparado, a manera de introducción al tema que hoy vamos a tratar, unas láminas que me voy a permitir pasar, si me permite el moderador de la sesión. Me gustaría compartir con ustedes algunas láminas. Espero que se vean muy bien las láminas. Bien, la salud de las personas, la salud de las poblaciones, es un amplio mundo que convoca necesariamente a varios profesionales, porque la atención en salud tiene diversos niveles. Hay un nivel de molecular o celular. Hay otro nivel de atención en salud, que es el nivel individual, y hay un nivel comunitario. Para estos niveles de atención de salud se requieren diferentes tipos de profesionales, desde investigadores en el campo de la biomedicina para la atención a nivel molecular de la salud. Hay también necesidad de profesionales de práctica clínica, de la medicina clínica, para atender a nivel individual la salud de las personas. Por supuesto, también hay un nivel de atención comunitario o de población que está a cargo de profesionales de salud pública. Por eso es que la atención en la salud requiere necesariamente de una actividad interprofesional e interdisciplinaria. Esa es, pues, la razón por la cual en el campo de la salud tenemos que converger, unir los esfuerzos diferentes profesionales de la salud. En la situación de pandemia en la cual hoy nos encontramos, se requiere de estos tres campos de acción: del campo de la salud, del campo de la atención médica y del campo de la biomedicina. En el campo de la salud pública es necesaria la participación de los profesionales de salud pública para definir estrategias de atención integrales para la pandemia. También es necesaria una vigilancia epidemiológica efectiva. Por el lado de la atención médica, se requieren tratamientos efectivos y oportunos para las personas que están enfermas por COVID-19. Pero también es necesaria la participación de los profesionales médicos, de todos quienes trabajan en el campo de la clínica, para reducir las tasas de mortalidad, sobre todo la letalidad. Desde luego, necesitamos también los investigadores en el campo de la atención, de la biomedicina, para descubrir nuevos tratamientos que protejan a las personas enfermas y que eviten que éstas mueran. También requerimos este campo biomédico para descubrir nuevas vacunas. Ahora el mundo está trabajando intensamente en la producción de vacunas. Por eso es que en los tiempos es necesaria, indispensable, la cooperación entre la salud pública y la atención médica. Es absolutamente indispensable. Por eso es importante esta reunión que hoy tenemos, en la cual vamos a tener la participación de destacados profesionales del campo de la salud. Algunos se dedican a la investigación, otros a la atención médica y otros más a las partes de la administración y la salud pública. Voy a ir presentando cada uno de los oradores, de los speakers, y tenemos el gusto, en primer lugar, tengo el gusto de presentar a la doctora Carline Ricis. La doctora Reidix, ella es médica en salud pública y líder en administración de salud en el Caribe. Ella terminó sus estudios de medicina en la Universidad de St. George, en Granada, y además hizo una residencia combinada en medicina interna y pediatría en los Estados Unidos. Posteriormente, ella estudió salud ocupacional y salud ambiental y obtuvo el grado de maestría en salud pública. Obtuvo el grado de máster en Public Health. Ella volvió al Caribe y ha ocupado diversas posiciones en la medicina clínica, en la academia, en la salud pública y en la administración. También ha sido consultora para agencias regionales e internacionales de salud pública. El propósito principal de su vida, según ella nos refiere, es contribuir a la realización de todas las personas, de cada una de las personas, a que desarrollen todo su potencial mediante estrategias de colaboración con aliados para conseguir el uso de las mejores prácticas y las tecnologías para mejorar y construir sistemas de salud sostenibles y resilientes. Actualmente, ella es la jefa de la División Social y Humana de la Organización de Estados del Caribe Oriental. Esta división tiene como finalidad hacer adquisiciones o compras conjuntas en esta región del Caribe, pero también se ocupa de la salud, la educación y la protección social. Doctora Reidix, tiene usted la palabra para hablar sobre la compra conjunta, los servicios de compra conjunta en los estados del Caribe Oriental. Adelante, doctor.
Thank you very much for that introduction, Dr. Santa Cruz. And it's my pleasure to be here as part of this webinar. So thank you to Universities Caribbean, UDUAL, and I'm sure I would mispronounce the acronym, ECESELI, for putting together this webinar and for inviting me to speak on this topic. Would you like me to share my slides? Yes? Okay. Okay, so you're sharing my slides for me. That's great. Thank you very much. So for the next 20 minutes or so, I'm going to be talking to you about the OECS PPS, Pooled Procurement Service, and the COVID-19 response. Next, please. Okay, so the objectives of this presentation is to share with you the model of the OECS PPS, which has been around now for over 35 years, to show the impact of the OECS PPS since its inception, and to outline OECS PPS's response to date to the COVID-19 pandemic. Next, please. So just for those of you who may not know, I just want to give you an idea of what the OECS is, the Organization of Eastern Caribbean States. And so this organization of the Eastern Caribbean States, the Caribbean small islands which form the eastern border of the Caribbean Sea, is an intergovernmental organization which was formed by the Treaty of Bastille in 1981 and further consolidated by the formation of an economic union in 2010. So just to hear a little bit from our staff at the OECS Commission, which acts as its secretariat, I'm just going to show this video. Next, please. And you can see the islands there in that map. Are you able to play the video? Yes. We're not able to hear the audio. Okay, so while we wait for that, I think, oh, there we go again.
Welcome to the Commission of the Organization of Eastern Caribbean States.
Located in Castries, St. Lucia, the OECS Commission is led by a Director General and one Commissioner from each OECS member country.
As the guardian of the revised Treaty of Bastille, the Commission serves as the executive organ of the organization.
The Commission is actively leading the execution of several projects and initiatives
to advance, support, and accelerate regional trade, economic, and social integration.
To mainstream climate, economic, environmental, and social resilience.
And to promote equity and social inclusion.
We delivered free movement and indefinite stay for all citizens across OECS protocol member states.
We continue to deliver safe and cost-effective medicines.
We deliver training, technical support, goods, and financing for advancements in education, agriculture, health, local business development, trade, social development, and environmental sustainability.
The OECS Commission continues to create opportunities and partnerships to deliver results.
Because we care about our region and our people.
Thank you. So that was just 1 minute to give you an idea of what we do. So let me tell you a bit more about OECS PPS, the Pooled Procurement Service, which started off as the Eastern Caribbean Drug Service. This was established in 1986 with a permanent secretariat at the OECS Their payments are facilitated through the Eastern Caribbean Central Bank. You may know that English-speaking Eastern Caribbean countries share a common currency and an economic common union. It is a self-financing mechanism and became so in 1989 with a surcharge being charged by member states. But because of the small populations, it's been able to save member states several $1 million a year in medicines and medical supplies. At this time, there are over 840 medical products with 30 suppliers that we purchase collectively for the English-speaking Caribbean, including medications, medical supplies, things like syringes, needles, IV fluids, etc. There's a joint tenders and awards committee and a central buying unit. And you can see there the member states that are represented in this mechanism. Next, please. So the reasons for having a pool system are obvious. If you know the range of population in the countries that make up this mechanism, it ranges from as little as 5,000 to as much as 170,000 population. So the need to be able to pool to come up with some economies of scale is important. Before this pool system, we had extreme variations of pricing across member states, often due to smaller orders. There are various levels of development of medicines regulatory systems. I'm hearing an echo. If I can ask if persons can please mute their mics if they are open, please. Or if the host can mute the mics for me. Okay, so yeah, I'm still hearing an echo. Maybe I need to put it in the chat if you're not hearing me. Okay, still one more.
That's done. That's good. That's fine.
Okay, great. Thank you. It's very distracting when I'm hearing myself, and so it's going to cause me to keep stopping. In terms of the benefits to the member states, obviously the economies of scale, they've been able to benefit from a 20% decrease in pricing. And through the system, there's a fixed common price for each 2-year tender cycle. This has facilitated 100% availability of antiretroviral medications and 90% availability of other identified essential medicines. The non-economic benefits we've mentioned before, which include enhanced quality assurance, coordinating trading, research, monitoring, and evaluation, and having a harmonized formulary and regional cooperation and integration. Next, please. And the PPS contributes to SCG 3, specifically 3B, providing access to affordable essential medicines and vaccines. Next. So OECS PPS has several services. We go beyond just procurement. We assist with regards to the selection through the Technical Advisory Committee. We help member states with quantification and forecasting. Of course, there's procurement. While we don't do warehousing, we help with technical support of warehousing and distribution in country, as well as give some idea of what's happening with prescribing and feedback through medical utilization reviews. Next. Here we see the tenders subcommittee. So it's a joint mechanism. There's representatives from each member state that sit on the committee that evaluates the bids to determine the awards. So it's done as a collective process. Next, please. Most recently, the PPS, which was the Pharmaceutical Procurement Service, has expanded to become what we call the Pooled Procurement Service, so that we can give, so that we can use these economies of scale beyond essential medical supplies. Two areas that we've looked at include Well, within medical supplies, one of the areas we had earmarked to expand to was laboratory supplies, because up until recently, lab supplies were still procured by each individual country. In addition, education supplies, including electronic devices, and post-disaster response supplies. In 2017, when more than half of our member states were affected by hurricanes for that season, we saw the need for pooled procurement of those kinds of responses. Next, please. And of course, in all of this, the need to strengthen the capacity of countries for early warning, risk reduction, and management of national and global health risks is also big on our agenda. So the ability to respond in terms of international health regulations, capacity, and health emergency preparedness was one of the new areas in which PPS had decided at the beginning of our strategic triennium, which was about 3 years ago, to further its action. Next, please. As part of this, in early 2020, this was in about December, January of 2020, in January actually, this was in January of 2020, we held a workshop with the assistance of USAID through their Global Supply Chain Management Workshop to look at our PPS, our Pool Procurement Service, and see where we were in terms of strengthening emergency preparedness for disease outbreaks. At the time, the COVID-19 was just something we were hearing about on the other side of the world, somewhere in China, that seemed to be something that was distant from us. Next slide. It's difficult to read, there's a lot on this slide, but what I want you to take away from this is that we realized that there were several areas of work that we needed to work on to help be able to respond in terms of emergencies. This included commodity forecasting ahead of time for emergencies for different types of disease outbreaks, procuring and sourcing again ahead of time, having agreements in place, stockpiling, because our model included ordering in bulk, but having delivery go directly to member states. And so there is no warehousing facility associated with the PPS. So stockpiling, warehousing, and storage, these were some of the things we needed to think about and review. And then transportation and waste management. Transportation, especially within the region. So how do we transport within countries, but also how do we transport between countries, which would allow for exchange and better distribution between countries. And then, of course, data visibility, having an idea of what stock is available in each member state so that we can easily redistribute as needed in times of emergency. So these were areas identified that we needed to work on as a PPS. Next slide. So, as you know, since March of last year, with the declaration of the pandemic, we have all been facing COVID-19. And to date, globally, there's been over 105 million confirmed cases and 2.3 million deaths from COVID-19. The impact from COVID-19 has been bigger than we ever expected when we made the plans to improve our ability to respond. I think I've lost my slides. That's okay, you can just go to the next slide. Yeah, thank you for that. This shows you where we are today in terms of globally, what the figures look like. And we all individually and collectively have been impacted. I can say I know family members of colleagues who have passed away from this disease. both within the region and outside of the region, both in the European continent and in the USA and Canada. We know that we have quite a diaspora and a connection between these countries, and we've all been affected. But just take a look at this slide in terms of what is happening with COVID-19. Not only is it directly impacting people's health, but look at what the impact that it's having on our health system. Healthcare disruptions could reverse decades of improvements. Interrupted childhood immunization programs in around 70 countries. Illnesses and deaths from communicable diseases spike. Progress in many health areas continued but needs acceleration. So the COVID-19 is impacting health across the board, not just the way it impacts directly. Next slide, please. And I'm not sure who said this quote, but I think it's very relevant. Some have described the battle against COVID-19 as a war. And the quote says that heroes may win battles, but it is capable supply chain systems that win wars. When you're in a war, if the persons at the front line of that war cannot get the supplies that they need in order to carry out what they need to carry out, then it's game over. And a big part of responding to COVID-19 has been not just what Dr. Santa Cruz so ably put together in terms of the different aspects of the cellular, the individual, and the systems approach, but how do we get the tools or the weapons of war to the frontline workers, to those systems? How do we connect the dots to ensure that things are going to work? Next slide, please. So with COVID-19, from the beginning, we've had several challenges, even associated with the regular types of supplies that we always bought from our regular suppliers. Because prior to COVID-19, countries bought masks, personal protective equipment needed for general use in hospitals and healthcare settings through the pooled procurement. But we noted that there was limited market availability of products due to supply chain disruptions that were beyond our suppliers' controls. For new types of products, there was price gouging and requests for upfront payments for things to be delivered months in advance. There was a spike in counterfeit, falsified, and substandard products. We had governments competing for supply for critical response items, driving the price up rather than taking the kind of global approach that we've been able to now bring on board somewhat. And for smaller countries and regions like ours, we were at a supreme disadvantage because even with the pooling, we were still a very small market in the global market. There was a lack of capacity and an inability to execute large and rapid response procurement. Our procurement system was designed for a 2-year cycle with a locked-in price. And fast acquisition was prioritized over standards and transparency. And these inefficiencies and exorbitant costs around regional shipping, because with the breakdown of travel, with the initial travel bans, those same planes, which were often the regional transport mechanisms in emergencies, those systems were compromised. Next slide, please. So OECS had to act. We needed to consolidate orders to command the attention of vendors, manage costs all the way to the delivery endpoints, and ensure that each transaction continued to be transparent and competitive as best we could. Next. And the solution, of course, was partnerships. So we needed to now partner beyond our initial partnership between the OECS member states. One of the first partnerships we built was with the Easy Buy procurement solution, which allowed us to have an electronic platform, a strong digital infrastructure that applied the standards and allowed us to put through single tenders quickly for large supplies in response to COVID-19 alongside our existing traditional mechanism. Next, please. We also became part of the regional mechanism. Here, we also facilitated our partnerships with existing international NGOs, things like Direct Relief, and we're able to consolidate and redistribute supplies to member states. Here you see, even though we haven't done warehousing, we received a supply of the N95 masks, which we were able to then distribute to member states. And we were also able to facilitate resource sharing and exchange. This is something that PPS traditionally did. So that if one member state, for example, was running out of a supply of something that another member state had on hand, we were able to facilitate exchange. And in the COVID-19 crisis, we were able to do the same, facilitating exchange of medications and devices as each country went through its own blips in terms of cases. Next. We also became part of the larger regional Caribbean community procurement cell, which was put together by CARICOM to include the Disaster Management Agency, the academic UWI, and the Caribbean Public Health Agency, in ensuring that we could find ways to procure, even on a larger scale, beyond OECS PPS for needs of member states. Next slide. And of course, we were not alone. Globally, we've seen the theme of partnerships across the board. A few months in, the UN Procurement Platform was created and is being used across the globe to facilitate procurement of COVID-19 supplies. The African countries have formed a medical supplies platform to ensure that each country can get a certain amount of supplies across, and so that there is not competition between countries. And they have included the CARICOM countries in the access to this supply network, again, being able to benefit from larger economies of scale. We know globally the Access to COVID-19 Tools Accelerator is looking at trying to level the playing field. And one pillar of that is COVAX. And I'm sure one of my panel colleagues may go more into this. Next slide, please. So we continued not only to respond to COVID-19, but the usual work that had to continue. So we needed to ensure that countries had their usual supply of medications and medical supplies. And we noticed that member states stopped paying attention to those things. So we had to go a bit further and handhold a bit more, forecasting for them, ordering for them to make sure that those things did not fall off the bandwagon. Next, please. It also allowed us an opportunity to fast track as a region for OECS, the free movement of goods between islands within the OECS. Because the disruption of regional air travel meant that we became more reliant on sea travel, on boats going through, and we became more aware of the fees and the barriers to being able to transport goods between islands. We needed to have large supplies dropped off at one island and then transported by boat to the neighboring islands. So we've been able to set up a central warehouse in Antigua and dispatch from here to several member states. Next, please. So to date, we have delivered through mobilization, bilateral partnerships, $2.16 million EC dollars worth of supplies and equipment in direct response to COVID-19. This has included PPE, PCR test kits, viral swabs, ventilators, and ICU medication kits. And we're looking forward to helping to facilitate the procurement of COVID-19 vaccines as we go into this phase of vaccination. Next, please. So I will end here on this slide with this I've been told it's an African proverb that if you want to go fast, you go alone. But if you want to go far, you go together. In responding to COVID-19, we have to go far and we have to go fast. And so we need all hands on deck. In keeping with target 17 of the Sustainable Development Goals, partnership for the goals, we need to work together in order to fight this COVID-19. I thank you for your attention.
Muchas gracias, doctora Reidis, por recordarnos en esta sesión la importancia de hacer alianzas para poder enfrentar problemas tan complicados como esta pandemia. Y usted nos ha recordado claramente que para ganar una batalla no son solamente necesarios los soldados en el frente de batalla, el personal sanitario, sino todos los insumos que ellos requieren para poder hacer su trabajo. Muchas gracias, doctora Reidis. Our next speaker, nuestro próximo orador es el doctor Azir, Jabor Azir. Él es médico con una doble certificación, tanto en medicina posteriormente su pasantía en el Hospital Regional de Cornwall, de Montego Bay, Jamaica, y hizo su práctica de residente en el Hospital de la Universidad París Diderot, París 7. Sus áreas de interés, por supuesto, por la especialidad que él tiene, son la medicina crítica, la emergencia médica, el paro cardíaco, la medicina tropical, la medicina interna y la toxicología clínica. Tiene una vasta formación. Sí. Él es además profesor de estudiantes de medicina y enfermería del Hospital Universitario de Martinique, Francia, y es miembro de la Sociedad Francesa y Europea de centros de envenenamiento y de toxicologistas clínicos, de toxicología clínica. Su filosofía, la filosofía del doctor Azir es la igualdad en el acceso a los tratamientos y al trato digno de los pacientes. Él además es un regionalista del Caribe, puesto que él cree en los principios fundamentales de trabajar juntos en los territorios del Caribe. Su visión es construir una cooperación regional médica entre los países del Caribe. Actualmente él trabaja en el Hospital Universitario en Martinique como un consultor en terapia intensiva y además es también el jefe de toxicología clínica. Doctor Azir, tanto gusto. Bienvenido a esta sesión. Adelante, tiene usted 20 minutos. Muchas gracias.
Your mic, le micro d'abord.
Sorry for that. Can you see my presentation?
Not yet.
Now? It's okay?
Yes.
Okay. Thank you very much, Dr. Javier. Muchas gracias por esta presentación. Good afternoon to everyone. I am Dr. Jabor Azir. I'm a consultant at the University Hospital of Martinique and Intensive Care Unit. I am very glad to be here this afternoon. And I would like to say thank you to Mrs. Moise Miriam for inviting me again. Last year I was there, and this afternoon I'm very glad to present to you some slide on the implementation of medical and scientific cooperation in the Caribbean and coronavirus pandemic. As I tell you, I'm not going to be long. Welcome everybody to that little presentation. So I'm not by myself. I represent the University Hospital of Martinique. Let me just give you some highlight about this hospital. So everybody knows we are a French territory. This hospital was born in 1980. The name was La Mena. That is French, but we're going to the English part. So that is a Caribbean center of excellence. So we got at least 1,600 beds and more likely 700 medical and 300 surgical beds. Those beds, they are not for French, or they are not for Martinican, Guadeloupean, and others. Those beds, they are for the Caribbean. So you will understand very well where I'm going, my point. So that is a well-equipped hospital with multiple resources. Like you can see, that building, that is the new refurbished building in 2017. We got actually 40 beds, ICU beds. So that is one of the big ICU in the region. I'm not talking about Puerto Rico and others, but in the region, in the East Caribbean, I think we have 40 beds, not only for us, but for the Caribbean. So the reason of my presentation is to talk a little bit about medical cooperation between the French departments of America and other Caribbean countries. For us, that has always been a priority and health issue in the face of major challenges. If you can see, the regional medical cooperation is one of the most appropriate responses to manage commune medical issues. Like you can see, the prevention and health education. Dr. Varela just spoke about that. Management of major national risk, and especially in the management of common regional tropical disease like leptospirosis, HIV/AIDS, chikungunya, dengue, Ebola, and more presently, COVID-19. So we got medical cooperation. For us, these are veritable exchange between colleagues. So what we're talking about when we talk about medical cooperation? So we believe that cooperation for us is the exchange. Exchange is a support. Exchange, training, dialogue to professional and our neighboring island, because we're not by ourselves. For that, we are living in islands. So we have 4 main areas where we are interested. Is training, teaching. Number 3 is care. Number 4 is the transportation. When we talk about transportation, we talk about the human resources. So we believe in collective institutional cooperation. We don't believe in individual cooperation. That is what we have been doing for years. And the question is, for the past 30 years, we have our networking with a lot of our colleagues. But we believe individual will is not enough. Even you will see in my presentation, we are fighting for the past 30 years to have some agreement from government to government in order to do what we call a proper medical cooperation. Today, those papers, they stay in some offices. We don't know what is going on for the past 30 years. But we're going to hospital cooperation. Let's go. So, is there really a medical cooperation? If you ask me that question today, I won't answer it. But it's up to you to understand that, and you will see. So in our case, what we do, we deal with all our countries or neighboring countries like OECS. We are part of the OECS, like Dr. Radix just said, and we do cooperation not only with our neighboring. We do cooperation with also French Guiana and other countries. So in 2014, we published our first paper and the West Indian Medical Journal, where we said cooperation between the French Caribbean French departments and surrounding countries appears to be indispensable. So we knew the problem was there. We knew we had to do something. So when we look at that paper, this little paper in implementation of medical and scientific cooperation, we did publish last year. We asked and we said that we need to have a new approach to international medical and scientific cooperation to face COVID-19. But it's not so easy. Not so easy because for us, a little bit easy, but because we understood the problem. We know that international medical cooperation in the Caribbean is a major asset for really the influence of that medicine, the French medicine, which is based on a really social, really exchange medicine with our colleagues. So, and this paper also, we did, I'm going to read a little bit because I don't have so much time. We said that the inter-regional cooperation between the French Department of the Americas and other Caribbean countries is essential for the implementation and improvement of healthcare. It is urgent for the Caribbean professional to discuss the possibilities of developing common solid relationship and training, collective scientific research, and continuous medical education. From 2014, we have been saying the same thing, but we will see what COVID will bring to us. Let's go through. From 2000, for the past 10 years, we have been working on our side. We got only help from Europe by Interreg. So you will see what we did with that money. We didn't put it in our pocket, but we did work for it. So we believe that collegial relationship and friendship is the key. So we try to establish the proper cooperation between St. Lucia and Dominica, because in the south we have St. Lucia, and the north we have Dominica. There we go. So we try to say that we're going to train nurses. The only thing we can do for them is to export, is to give them the same knowledge we have in order for them to treat them people. Martinique doctors have become integrated into Caribbean medical groups. Research, teaching, training, and training physicians and nurses. And today we are proud to say that we have been trained 40 nurses from St. Lucia, Dominica, and 4 doctors in the neighboring island. A new approach, we believe in that, and medical cooperation, and period of public health crisis like now. Not only now, because in chikungunya, we have seen the same problem, in dengue, Ebola, Zika, and today, COVID-19. So we believe that resilient healthcare procedure is important. We believe that we need that kind of regional cooperation for better access to medical information, like with CARFA, OECS, PAHO. We believe that a new approach, we believe in that not only in COVID-19, but in critical events like the earthquake in Haiti, we were there. We look for that. Zika epidemic in 2015, invasion of Sargassum in the Caribbean, the Irma hurricanes, Maria, the pandemic also. We had to organize our service, our capacity, because we know we're not by ourselves. When St. Lucia is doing bad, we know when Dominica is doing bad, we are doing very, very, very bad. And the Sargassum crisis, not everybody listened to us, but we for the first moment in 2018, we did publish a Lancet. We said Sargassum, seaweed on the Caribbean island, that was an international public health concern. But those English people, they didn't understand us. They published our letter immediately. But some people in the Caribbean, they didn't understand us. We believe in a new approach, and the French air bridge for circulatory support. Some countries, they don't have the same technology than us. Like in French Guyana, in this case, we published this paper in 2012. We said that in our cooperation, we did provide support to patients in refractory shock, patients really sick in the Caribbean. This is what we do. We don't stay there. We said, and some pathologies like envenomation, snake envenomation, which is a really neglected, one of the most neglected diseases in the world, because we have more than 150,000 people die in the world every year. So we did our cooperation with University of Costa Rica, with Jose Maria Gutierrez, which is my boss. So we said in this paper, snake envenomation in the Caribbean, the role of medical scientific cooperation, because some of the countries, they didn't even have what we call antivenom, which is a treatment to avoid that kind of death. And we published in this paper. We published this paper where we demonstrate that we have some big venomous snakes in the Caribbean. We don't have time to explain that, but when we look at the Suriname and St. Lucia, Guyana, French Guyana, Belize, and Trinidad, Tobago, Martinique, St. Lucia, we got a lot of venomous snakes. We need to talk about that one day. We don't stay there. Everybody was waiting for a good time, but we knew very well that bad times will come with COVID-19. Everybody in the world in 2019, I was in Paris in the Congress where one of my friends at Bichat Hospital, the first hospital in Paris, we received the first 2 patients. He told me there is a rare disease, something we don't know. Do you have time to go to see those patients? And Bichat, I said, no, I didn't have time, but it was a mistake. I went to United States. When I came back in March, so we got the first case in the Caribbean. So you will see today, we're not going to talk about that, but you know more about, the news. And in the case of Martinique, we have seen for the past 1 year, 6,500 patients. We have seen in ICU more than 80 patients with 40 deaths. The number of patients in the world is increasing, but we're not going to talk much about that disease. But the only thing we have to say, that is a vascular disease. That is a ARN virus. Everybody knows about that. When you look at the physiopathology of that disease, there's a lot of things we don't know. We know the T lymphocyte cells is in trouble. We know that this is the patient we have seen in ICU. We know that there is a storm of inflammation. We know there is a lot of thrombus. And when we look at the physiopathology, the time is running, but we know that virus invade all our cells, especially in the pulmonary and the invasion and in the pulmonary. We know this problem. So when we look at that, we know there is an endothelium injury, and for that, the majority of those patients, they finish in ARDS, acute respiratory distress syndrome, and we are dealing with something special. When we look at the management, we for the first moment with that disease, we put a WhatsApp where we have 150 members in the Caribbean. Every Friday we discuss between us. So that was our contribution, our first contribution. The second contribution was to train our colleagues. Like now in St. Lucia, last Friday, we had a meeting with them. We explained to them the question they were asking us: what do you do in your ICU to treat those patients? We answer to them: you don't have to kill yourself. We are in trouble. But we don't do so much, because the only thing we do, you need to have oxygen therapy. You need to have some good ventilators. You need to have non-invasive ventilation like OptiFlow. You need to have enough corticosteroid. You need to have anticoagulant. You need to have what we call discipline, multidisciplinary approach. So you need to organize yourself. It's not finished yet because we are here for long. You need to have proper communication between you. COVID-19 can unify, can put us together. You need to have a good collaboration. If you never call your neighbor, you need to call him because we are in trouble. Be patient. Don't give up when you have a patient, because some of them in ICU, they will stay for 90 days, for almost 3-4 months. You need to be patient. So to do so, you need to organize your country. This is what we're talking about. So we did organize our country. Here you have our intensive care unit. That is the COVID. You are in the COVID side and the right side, and you can see in the door you have COVID ICU. So when we compare the ICU with our colleague in St. Lucia, you can see that comparison is just to help you, to show you with 35 miles only what is the difference in healthcare. You do public health, you understand very well. So here, this picture is from last week. Here you have Victoria Hospital, 3 beds ICU, 1, 2, 3. And when you compare down there, intensive care unit in Martinique, you have that. This patient is come from St. Lucia. Just to tell you that we're not here to talk about medical occupation and we don't bring anything. The essential thing is to put your hand and to work with your colleague to exchange not only with words, with action. That is it. The action is not only that. We believe the paper we published last year, I believe a lot of colleagues in the Caribbean, they never read it, because we said in this paper, block change, we need to have a platform in the Caribbean. We need to have a platform, medical platform, where everybody is going to connect at the same time when we have to deal with a patient. We believe that block change and healthcare is the key. Doctors will be able to share research results, to facilitate new drug and treatment, especially in the moment where the borders are closed. So we need to do that. We don't have to wait for United States or Europe to tell us what to do. We can do that. Blockchain is my idea. And when we look at the blockchain healthcare in the Caribbean, if somebody wants to support us, we will share information, medical information. We will give privacy to our patient. We will stop to send docket of our patient with a piece of paper and talk on the phone. Everybody knows what the patient has. Blockchain in the Caribbean is the reality. So in case of medical emergency, not only what has happened, since 1987, we have an Intergovernmental Agreement. They never signed it between St. Lucia and Martinique. If you tell me why, you have to investigate yourself. My presentation is a medical presentation. Prior attempt for telemedicine in the past, before me, I was in Paris, I didn't know about that. But today, that telemedicine, I don't see it. Continuous cooperation between physicians, yes, this is what we do. We said, okay, you don't want to sign the agreement, we're going to do hospital to hospital. Because you cannot stop us to talk. That is the exchange, and this is what I think you have to support. So, to I think COVID-19 gives us a lot of lessons. The first one, you have to prepare your country to face, because you will be by yourself, alone. Second lesson, the Caribbean region is not immune. It's not. A lot of people think, yeah, we're not going to have a lot of cases. We said at the beginning, we will face a big problem. We need to prepare ourselves. And you see some countries today, they are lying to themselves. They said they have enough ICU beds, enough drugs. It's not what we have seen. They need to prepare better. We have to build our capacity. We have to increase all those things and disaster period. So the Caribbean region, being heavily dependent on tourism, has suffered. It's not my part economically, like all countries in the world. But we need to save our people. The COVID-19 was an illustration of solidarity, and we can see that today. So it's more likely those illustrations. We need more cooperation between those governments, the CARICOM, the PAHO, the CAFA, OECS, and other organizations. We need to do that. And this medical cooperation, the COVID-19, allow some government to transfer friendly government for expansion ICU capacity. This is what we did. We gave 50 beds to St. Lucia. We do things. We continue to work with them, with our colleagues. And we talk every day. Such cooperation needs to be maintained as a permanent future of regional healthcare provision, not only in COVID-19, not only in Zika, not only in that. Both regional, global cooperation among government and international agencies will be the key. So, but to do so, we need to work together. But we have some current limitations. I want to share them with you. That is the of the last slide. Funding issue. The medical cooperation in Martinique is a cooperation based on a lot of things. You will say it is humanitarian cooperation or whatever. We don't know yet. We don't have name. The only name we have, we know we can communicate today with our colleague. Everybody has a phone. Everybody has our WhatsApp. Before, we didn't have that. Individual cooperation, I don't believe in that. We need collective cooperation. That is what you're doing now, that presentation this morning. No common teaching program in medical universities. I don't see some of them, really. Cooperation agreement between actors. I don't see so much. The immigration issue, who is going to talk about that? The medical evacuation of patients. We have air ambulance problem. We have problem of finance. If you are a young guy, 24 years old, you're really sick, and those countries, if the government doesn't help, you're going to die. Interreg cares help us to do medical cooperation. We need to ask for more help. But in the Caribbean, some organizations need to put something into. In conclusion, the COVID-19 pandemic has demonstrated unequivocally the values of multilateralism. He has relieved an urgent need to expand capacity for human resources, healthcare infrastructure, and the national level. These two-pronged approach may be the only effective method to deal with that pandemic. I was a little bit quick, but I hope the message is there. Thank you very much. We have a simple cooperation based on training, teaching, and human resources. Thank you very much, Miriam, also for inviting me a second time. I hope I will get more invitations in the future. Thank you. Thank you.
Muchas gracias, doctor Azir. Quienes lo hemos escuchado esta mañana, podemos entender mejor ahora su filosofía su filosofía del tratamiento igualitario para todos los pacientes, su filosofía de creer firmemente en la alianza de los países del Caribe, no solamente de habla francesa, sino también de habla inglesa y de habla hispana. Usted mismo es una muestra de ello, porque usted estudió medicina en Puebla, una ciudad muy bonita de este país, de México, donde usted comió excelente comida y saboreó muy buenos dulces. Pero también usted mismo ha solicitado la colaboración del Instituto Clodomiro Picado de la Universidad de Costa Rica. Lo que quiero destacar es que la alianza debe ser entre los países del Caribe, es verdad, pero también en los países de habla hispana como Puerto Rico. Está presente ahora gente de la Universidad de Puerto Rico. Estamos presentes nosotros desde México y les mandamos un abrazo solidario. Gracias, doctor Azir. Ahora entendemos mejor su filosofía. Muchas gracias.
Just to tell you, thank you very much. So I'm just the son of Michael Manley, Césaire, and if you don't forget about those guys, Michael Manley, talking about the cooperation in Jamaica, he has been working hard. He believes in the Caribbean and Caribbean countries. He believes in the Caribbean open to the world, and medicine also we can do the same thing.
Gracias, doctor Azir. Muchas gracias. Bueno, voy a presentar a nuestro próximo panelista. Voy a presentar al doctor. Ahora déjenme poner una transparencia. Voy a ver si puedo compartirla para hablar ahora de nuestro próximo orador, que es el doctor Harris, el doctor Orlando Harris. Él, como ustedes pueden ver, tiene un rasgo muy personal. Él se dedica a la investigación, él es investigador. Además, él utiliza un método de investigación participativa basada en la comunidad, tanto en los Estados Unidos como en el Caribe, utilizando o aprovechando datos de multimétodos que informan, que nos dan información acerca de intervenciones relevantes para mejorar la vida de las minorías de género sexualmente vulnerables. Investigaciones han permitido dar voz a las minorías de género y sexual, tanto en Jamaica como de manera más amplia en el Caribe anglófono, con el fin de reducir las disparidades en las comunidades marginalizadas. Él nos hablará del impacto del nacionalismo contra el COVID-19 en países de ingresos medios y bajos y cuáles son las implicaciones para los programas de vacunación del Caribe. Doctor Harris, bienvenido a esta reunión y adelante, tiene usted 20 minutos.
Gracias, Dr. Valera. Good morning, everyone. I'm going to go ahead and share my screen and then continue from there. Let me just make sure that I can do this correctly. Let's see. Oops. Are folks able to see my screen?
Yes.
Yes. Okay, excellent. All right. Good morning again, everyone.
Just to say that we're seeing the two slides side by side mode, not the full presentation
hang on
mode.
a second. Let me see if I can not do slideshow on this.
Maybe if you swap displays.
Let's see. How do you swap the display? Let me just,
right at the top.
I see it. I see it. Perfect. Oh, look at that. That goes to show you that technological challenges is not associated with just with age. Good morning, everyone. Dr. Orlando Harris. I am an assistant professor here in our Department of Community Health Systems in the School of Nursing here, and also in the Department of Medicine at the University of California, San Francisco. I just want to make it clear that I have no perceived or actual conflict of interest. This is solely research that I'm involved in through my work as an expert panelist on the COVID Prevention Trials Network through the funded by the National Institute of Health, and also just as an HIV/AIDS researcher here in San Francisco. Interestingly, we know that the COVID-19 or SARS-CoV-2 virus has impacted the globe in terms of an increased amount of infections, around 160 million so far since COVID-19 first emerged. And what we're seeing now is a daily average of up to 460,000 new cases per day globally, with an average, a 7-day average of around 482,000. And with that, you also see the same increase in COVID-related deaths. So as of this morning, it was around 2.3 million cases globally. Now, in terms of the impact of SARS-CoV-2 on Latin America and the Caribbean, roughly around 19 million or so cases have been reported in Latin America and the Caribbean, with majority of those cases in Brazil, which is averaging around 45,000 new cases each day. And these are the top 5 countries that are averaging really high coronavirus cases on a daily basis. We see the same trends in death, with around 618,000 deaths reported in the region, with, again, in this, on the flip side of this, Mexico reporting the most deaths each day, followed by Brazil, but those countries are still in the top 5. Now, when we think of vaccine nationalism, this thought, a significant amount of work have started to emerge, our body of literature is starting to emerge around vaccine nationalism in terms of just different countries, I want to say high-income countries, hoarding or reaching out to pharmaceutical companies to jump the line on vaccine availability. But when I think about vaccine nationalism, I have to think about political climate here in the US in terms of our previous administration and what that meant around America First. And I'll go into that in a minute. But when we think of vaccine nationalism, it occurs when governments sign on agreements, or they pay this a tremendous amount of money to jump the line. And when I say jump the line, many of these same countries have invested in vaccine development. I can think of here Operation Warp Speed in the United States. And we can have a separate conversation as to why that name was problematic, Operation Warp Speed, partly because it adds to a lot of the vaccine hesitancy that we're seeing here in the US. And I will also surmise to say in the Caribbean and Latin America as well, in terms of the rush to get a vaccine and people just not trusting it. But when we think of vaccine nationalism, Canada became the 3rd country after Great Britain and Bahrain to actually grant emergency approval. And so I remember watching on TV, and you've seen the first patients in the UK being vaccinated, and many Americans were wondering if it was America First or Operation Warp Speed. Why is it taking so long for the US to join those other countries? And shortly after, the FDA issued the Emergency Use Authorization, EAU. Now, we can't think of America First, we can't think of vaccine nationalism without looking at them as one and the same. Something that's cloaked in colonial racism, disparities, structure, partly because you see here where you have countries that are exhibiting nationalistic behavior because they have high income, may exclude many low and middle income countries and small island developing states from gaining access to COVID-19. And of course, according to the Rand Corporation, the costs to vaccine nationalism could amount to about 1.2 trillion a year in GDP. So vaccination nationalism signals that as long as the virus is not under control in all regions of the world, there will continue to be a global cost associated with COVID-19. Of course, with that becomes prolonged negative economic uncertainty across the globe. And I can think of in many places in the region, like in the Caribbean, where many of those islands rely on tourism as a means of GDP. And we've seen how many of these territories have taken a huge hit because of travel bans, say from the UK or Canada, which just instituted a travel ban to the Caribbean, partly because this is the time of year where many what we call snowbirds, or many Europeans and Americans will go to the Caribbean to escape the winter. So you see a lot of imposed travel bans that are affecting economies. Now, when we think of the same, like I said, we have to think nationalism, we think of colonialism. This vaccination nationalism signals that as long as the virus is not under control, like I mentioned before, you will see possibly mutation of the virus in other areas. So as we move to get the US, Canada, and most of Europe vaccinated, and we ignore folks in Latin American, Caribbean countries, we end up risk public health issues here in the US too as well, in terms of virus mutation or prolonged illness. Now, the other side to this is the economic costs. So the lack of equitable access to vaccines could cost the global economy roughly around 153 billion. The United States alone could lose upwards of 16 million, and we have other high income countries could also collectively lose around 39 billion a year. And I think one of the arguments to counter those who are nationalist, in the US we have a white nationalist problem, but to counter some of that is to bring on the economic perspective. One thing I do know about U.S. politicians here, especially those on the conservative movement, you boil things down to dollars and cents, and they understand that. And to say that we put America first and everyone else last, that will have economic consequences here for our country. Now, it is estimated that many of these countries, high-income countries, could lose upwards of $119 billion a year if the poorest countries are denied adequate supply to COVID-19 vaccines. So that's the economic argument. We can talk about the public health argument too as well on the other side. So, when we think of vaccine nationalism and boil it down to dollars and cents, for every $1 spent, high-income countries could get back almost $5 if we made vaccine access equitable. Now, the global coordinated multilateral effort is key to fighting this the pandemic. And if we think of it, it has major public health consequence, like I said before. But I'll go a step further in saying, at least here for the U.S. and Latin American and Caribbean countries, there's also a national security issue or perspective that we can think of. Understanding the mutation of viruses, the potential for a mutant strain. We saw different variants in South Africa and also in the UK, and now here in the US, and the potential for many of those mutations not responding to the vaccine adequately. Now, we talked about the economic incentives in terms of if you provide vaccines to these countries, you could save money on the other side of that. Now, if too many countries follow this vaccine nationalism perspective or approach, it could seriously hurt global equitable access for those most at risk. Now, with that on one side, we see that the Latin American and Caribbean countries are not comparable to their plans for vaccines are not comparable plans elsewhere because of the realities that they face are different. So several countries within the region have begun inoculation programs. I know, well, for instance, in Jamaica, their plan was to start rolling out the COVID-19 vaccine sometime in April. And because of supply and through PAHO and WHO, they have now announced that they will start their vaccination program at least 2 months early. So sometime this month, perhaps next week. But keep in mind that the vaccine will not be widely available in the entire region until the second half of 2021. And that's partly because of that vaccine nationalism perspective. Now, high-income countries have more options to acquire vaccines in addition to being more capable of monopolizing the vaccine production. So we're spending the money to develop this at warp speed. We deserve to have first access, that sort of mentality. Now, in LAC countries, there's a vaccination success tradition where we don't have, and I say we, speaking as a Jamaican American, we don't have the same level of, what do you call it, anti-vaxxers in the Caribbean the same way we do here in the US. And in fact, living here in the San Francisco Bay Area, the next county over is Marin, and that's like the heart of the anti-vax movement. The Caribbean and Latin America have eradicated many diseases that are still prevalent in other places. So we have had the success story in terms of vaccinating people in the Caribbean. Now, as we think about the sort of like the approval process, I know Dr. Radix had talked about COVAX, and I'll just talk a little bit more about that on the next slide. There's still a delayed rollout. I talked about Jamaica and just rolling out vaccines. In many places they haven't started. When countries in Latin America and the Caribbean can expect to get access to the first doses of the vaccine, that's sort of like delayed. Now, LAC countries have just recently started announcing their approvals for distribution. And one of the drug, I believe, that was approved recently was the AstraZeneca Oxford vaccine. And I'll show you one of the reasons why that might be an option in, say, LAC countries, and primarily because of cost. So in November, around November 2020, PAHO announced their plan to initially vaccinate 20% of the population in Latin America and the Caribbean, which roughly amounts to about $2 billion for at least 2 billion doses of vaccine by the end of 2021. Keep in mind, with many of these vaccine candidates, they're 2 dosing, so baseline, and some I think at 21, and then at 20, another at 28 days, but they're 2 time points. And so it adds to more costs. In December 2020, PAHO again convened a meeting with health ministries across the region, calling on member states to prepare for purchasing and distribution of the vaccine. So they also, with that, asked or require that ministries of health prioritize who will be first in line for the vaccine. And when we think about who will be first in line, we're seeing it here in the US, and I'm also concerned about equitable access. Now, like I mentioned before, the AstraZeneca vaccine amounts to about $4 per dose. So you think about $8 US or so for one person to receive the vaccine. And you see, as you go down the different lists, costs can become prohibitive. Now, low income countries in the region will be helped by the COVAX facility, which is, COVAX stands for it's, well, not an acronym, but it's the International Facility negotiating the purchase and distribution of vaccine doses through the access of COVID-19 tools, or ACT Accelerator. So WHO Alliance, this was an alliance that was created to ensure equitable access to the vaccine across the region. So while 28 self-financing countries have signed agreements with COVAX facility, they will have the option to purchase the vaccine through PAHO's revolving fund. And then, of course, this is expected to speed up vaccination. So 189 countries are participating in the COVAX initiative, with countries in the Americas representing about a fifth of the members. Now, despite this, the economic hardship that Latin America and the Caribbean countries have endured during the pandemic, they have also spent over $1 billion in down payments and financial agreements to engage with COVAX. So COVAX itself is likely, as mentioned before, to provide around 20% of participating countries' populations, so to vaccinate at least 20%. That's not enough, but it's a start. We've seen where Cuba is also developing their own vaccine, while Mexico, Argentina, Brazil have signaled agreements with Oxford AstraZeneca to manufacture its vaccine locally. And of course, if we want to get through this, we really have to make some of those intellectual property type materials available. So countries like what we see here with Mexico, Argentina, Brazil can start to manufacture the vaccine as well locally, which will help solve some of the problems in terms of transportation of the vaccine, cold supply chains, etc. Now with that, there are some regional challenges. Latin America and the Caribbean health systems can take a hit. So while stronger than many in other developing regions, it tends to be fragmented and chronically underfunded and have been under extreme stress battling the pandemic for almost a year. Now, couple that with the changes in with climate change, we see and the devastation of hurricanes and so on. We've seen where last year a lot of these countries in Latin America and the Caribbean had an uptick in COVID-19 cases, but also HIV and other diseases because of that shock of the healthcare infrastructure. The cost of vaccines and their distribution poses a heavy burden on these countries. Latin American Caribbean countries may also resort to cheaper vaccines, such as what we saw with Russia's Sputnik in Argentina, or China's vaccine, which is undergoing testing now in Brazil. While these vaccines are cheaper, they may be less effective. And of course, the other thing that we should consider as well is the politicization of the pandemic itself, which hinders rollout. We saw here in the US, we have folks who still don't want to wear masks. We have folks who are not interested in taking a vaccine. In fact, a recent conservative commentator, business owner here in the US, said on TV that folks shouldn't get the vaccine because it's the mark of the beast or whatever that is. But we see those negative attitudes that are impacting vaccination rollout here in the US. Now, going a bit further, we still see the stress on the system. I talked about the politicization of the pandemic. We saw it with Bolsonaro in Brazil, where he declared syringes too expensive and calling for a halt on government purchases until prices fall. So if you halt the purchase of syringes to administer the vaccine, you vaccinate less people, the potential for the virus to continue to spread emerges and people die. And we saw that from some of the slides that I had mentioned earlier. Now, just to wrap up, there's still vaccination challenges in the region. So despite the nationalism concern, we're concerned about lack of access to cold chain management systems, so how the vaccines are stored. We know that I believe it's one of the vaccines required to be below sub-zero temperature. And if you take it out of that environment, you must use it within 5 hours, or else it will lose its efficacy. We have those same challenges here in the US, where if you live out in rural areas of the country, you do have those cold chain management concerns. And of course, the transportation of the vaccine to the centers and the abilities of authorities to administer them. Like I said, you have a 5-hour window to do that. And I'll just to mention really quickly here in the US, one of the things that I've noticed that people are doing here in the US, those who really want the vaccine and you're not a part of that priority list at that point, they will wait around for hours outside these medical facilities, hospitals, pharmacies, etc., hoping that at the end of the day, whatever drop that's left in the vial, you can then inject them with it or else it's wasted. So a lot of pharmacies and hospitals, they will give non-priority list people the vaccine, the little bit that's left in that vial, so as to not to waste it. There are also problems with the definition of risk groups. And this obvious desire of several groups to be considered a priority. And then right now, I believe here in our state, it's persons 75 and older that are now being vaccinated. PAHO is working with member states to ensure their immunization programs are well prepared to roll out the vaccines as they receive them. And so all the stuff that I've talked about cold chain management, surveillance of adverse effects, information system, PAHO is working with these states to help establish those or to bolster those systems. And of course, we talked about the introduction readiness assessment tool, which is a tool for national authorities with a roadmap to monitor the progress in the introduction of the vaccines. And as I talk about, just to wrap up here, just listening with the information coming out of Jamaica, they will start with individuals in Group 1A. And then you see move down to, again, essential workers like law enforcement, persons age 65 years and older, and then other high-risk groups, and the remainder of the population. I will say some of the considerations that I have here is perhaps who will fit in those categories in terms of at-risk groups. Will we leave out the vulnerable, understanding that in the region, sometimes sexual and gender minorities are left behind, the poor are left behind. We've seen here in the US where if you're a member of a board or you're influential, you get to jump that line. And so we need to have a conversation about that too as well. We need to encourage international sharing of vaccines, and also need to encourage enforceable frameworks for vaccination distribution. And one major thing here is the implementation of sustainable international vaccination distribution programs in Latin America and the Caribbean. When I think of the enforceable framework, PEPFAR came to mind, and I strongly believe that for us to make vaccine distribution equitable, for us to ensure that marginalized and vulnerable individuals have access to the vaccine, we may perhaps need to adapt a PEPFAR model that mandated HIV treatment access to key populations. And they have a prescribed definition of what what is considered a key population. Now, until there's a widely available vaccine for COVID-19, physical distancing measures will continue to affect key sectors of the global economy. So think of industries where people need to be in close contacts. Think about resorts, the tourism sector, leisure sector, etc. And so it will still have a profound effect on those different sectors. And of course, we can't achieve vaccine success without combating misinformation. I'm still hearing a lot, especially from my family in Jamaica, that will send me, because they know I'm doing COVID vaccine research here in the US, and they'll send me YouTube videos or some video clip of someone saying that if you get the vaccine, they'll inject you with the 5G chip. And so, in my mind, I'm thinking, well, I don't know where you're getting this information from, but it's out there and it's causing a lot of people to believe this level of misinformation. And also we need to do more research or exploration of COVID vaccine hesitancy attitudes among all persons. specifically among young people. And I'm absolutely certain that a lot of the hesitancy that you're seeing or that we'll see is from that level of misinformation. And I'll stop there. And stop sharing.
Muchas gracias, doctor Harris. Muchas gracias. Vemos en su imagen al fondo el puente, uno de los puentes de la Bahía de San Francisco. Seguramente usted tiene una vista espectacular. Gracias por recordarnos que a pesar de ser una aldea global, somos una comunidad de países con grandes desigualdades, con grandes inequidades entre los países. Nuestra desigualdad está marcada no solamente desde el punto de vista étnico, sino también desde el punto de vista económico. También agradecemos que nos recuerde que el tema de la pandemia nos ha puesto sobre la mesa el tema de la ética, de la política, de la economía. Son varios enfoques los que hay que abordar al mismo tiempo para combatir eficazmente la pandemia. Gracias, doctor Harris, por esa visión tan amplia que nos ha puesto del costo que tienen las vacunas, los diferentes laboratorios, la politización de la vacunación, la capacidad adquisitiva que tienen los países, y eso nos pone en diferentes condiciones. Como usted ha dicho bien, los planes nacionales de vacunación no pueden ser exactamente los mismos porque tenemos realidades distintas y es responsabilidad de los sistemas de salud pensar bien cuál es el plan de vacunación que más conviene a su país y cómo pueden adquirir las vacunas de los laboratorios. Gracias, doctor Harris. Bueno, sin duda, tres oradores, la doctora Reitix, el doctor Ressier, el doctor Harris, que han dado una visión pues amplia del problema que tenemos enfrente, el cual no podremos resolver si no existe cooperación. Lo inter hoy está de moda, intersectorial, intergubernamental, interprofesionalismo, interdisciplinariedad. Lo inter es lo que nos puede ayudar a resolver la pandemia. Yo quisiera hasta acá detener mi participación agradeciendo a los organizadores habernos invitado para hacer esta moderación y quisiera darle la palabra al doctor Escalante, que espero ya tenga arreglado su sonido, para que él nos hable finalmente de los planes que tenemos para impulsar la producción de vacunas en esta parte del mundo, porque de otra manera nuestras economías no van a ser suficientes para poder adquirir las vacunas y para lograr un 70% de cobertura de vacunación en la población para alcanzar la inmunidad de rebaño. Doctor Escalante, si usted está de acuerdo, por favor, cierre usted o contribuya a finalizar esta reunión. Muchas gracias.
Muchas gracias, doctor Santa Cruz. ¿Me escuchan todos ahora sí?
Sí, muy bien.
Bueno, qué bueno. Bueno, primero que nada, saludo con mucho afecto a mi contraparte, la doctora Miriam Mois, secretaria ejecutiva de Universities Caribbean, con quien hemos conjuntado esfuerzos para llevar a cabo una serie de webinars y en este año 2021 este es el primero. Y me parece que el tema ha sido realmente muy afortunado. Saludo, por supuesto, al doctor Santa Cruz y a todos los panelistas que amablemente han participado. Yo creo que nuestros distinguidos panelistas han abordado lo que el doctor Santa Cruz decía efectivamente. O cooperamos entre todos o vamos a sufrir las consecuencias que ya estamos viendo y que el doctor Harris de manera muy precisa y muy adecuada mencionaba, este nacionalismo para la vacunación, en donde los países más ricos del mundo han acaparado las dosis de vacunas muy por encima del número de sus habitantes. Los Estados Unidos tiene un exceso de dosis que está muy por encima del número de norteamericanos que viven o de la población de ese país. Curiosamente, por ejemplo, Chile, un país latinoamericano, también ha adquirido una cantidad enorme de vacunas muy por encima de esto, para asegurar, ¿no?, que su país no solamente esté vacunada a toda su población, sino que además tome la delantera esté adelante en asuntos relacionados con la recuperación económica, ¿no? Porque les ha prometido incluso a los que visiten Chile, que los van a vacunar gratis. Entonces, para que estén en Chile, gasten dinero, en fin, y reactiven la actividad económica. Bien decía el doctor Santa Cruz que la UDUAL está promoviendo una reunión con la conferencia, con la Confederación de Estados Latinoamericanos y Caribeños, una reunión ministerial para llamar a los distintos proyectos latinoamericanos que hay para producir vacunas y tratar de ponerlos de acuerdo para que colaboren entre ellos y produzcamos nuestras propias vacunas, las vacunas que necesitamos para América Latina y el Caribe, y no tengamos que depender de estas disputas económicas que hay entre los grandes países ricos del mundo por acaparar las vacunas. Efectivamente, o este problema del COVID-19 se resuelve a nivel del orbe o no va a haber solución realmente para nadie. Entonces, yo creo que en este seminario, en este webinar, se han apuntado ideas muy importantes y que llaman a la colaboración y que entonces organizaciones como Universities Caribbean, como la UDUAL y otras redes, tenemos que reunir esfuerzos para reunir voces que apunten hacia esta cuestión. La colaboración latinoamericana y caribeña de nuestros expertos, de nuestros biólogos, de nuestros bioquímicos, de nuestros médicos, para que produzcamos nuestras propias vacunas y podamos resolver para todos el problema de esta terrible pandemia que nos afecta. Yo saludo de manera muy cordial a todos. Pronto les daremos noticias de cuándo va a ocurrir. Espero que muy pronto, estamos en eso. Este evento latinoamericano y caribeño a través de CELAC por supuesto, y los invitaremos a todos ustedes a que participen. Muchas gracias. Gracias, Miriam, por invitar a nuestros distinguidos oradores, y gracias al doctor Santa Cruz, un distinguido médico, secretario general de la Asociación Latinoamericana de Escuelas y Facultades de Medicina, la ALAFEM, que es un organismo también de la UDUAL, por haber moderado esta mesa. Un abrazo a todos y hasta el próximo webinar. Muchas gracias.
Gracias a los traductores que nos acercaron en esta reunión, y el idioma no debe ser una barrera para unirnos y enfrentar este problema común. Muchas gracias.
Muchas gracias. Chao.
Thank you so much. You can check the responses to the questions. Some of your questions have been. Thank you. Goodbye.
Goodbye.